speaker is Dr. Maneesh, who is going to take us through the different steps of the surgeries in advanced glaucoma. It's definitely a tricky situation, but he's going to give us the tips how to avoid the complications. Over to Dr. Maneesh.
Thank you, madam. Respected members on the dais, and thank you so much for having me part of this program. So I've been asked to discuss about surgical challenges and tips to avoid complication in advanced glaucoma. So next 10 minutes, I'll give you a very brief overview of what are the most common challenges which we face from a perspective of advanced glaucoma, although complications are similar in other glaucomas also, and some important tips. From surgery point of view, trabeculectomy is still the best surgical option because we know trabeculectomy can give you IOP in single digits and low teens. Direct cyclophotocoagulation we know has a high risk of vision loss, and MIGS and non-penetrating glaucoma surgery cannot achieve the target IOP which you want in advanced glaucoma, so they are not a good option for advanced glaucomas. Glaucoma shunt again are very, very good option, especially in failed TRAVs, but certain types of secondary glaucomas like neovascular glaucoma, uveitic glaucoma, post-retinal surgery, you can also use them as the primary option. If you're dealing with a case of primary angle closure glaucoma with very advanced cupping and you have early cataract with a shallow chamber, maybe removing the cataract will also help you to get more space and will definitely reduce your complications like malignant glaucoma. The most dreaded complication in advanced glaucoma is macular wipeout, but in reality it is very, very rarely reported. Basically, wipeout means a severe vision loss after surgery without any obvious cause. There have been multiple studies which have tried to find what could be the possibility of why there is no obvious cause, and they have found it could be because of retrobulbar anesthesia or even a large amount of peribulbar anesthesia causing pressure of the optic nerve. So whenever you are doing a surgery, avoid going too close to the optic nerve, avoid adrenaline. Sometimes a post-operative IOP spike or a hypotony can lead to some progression of glaucoma, can cause some macular edema, and that can lead to progression of the disease in already compromised eyes. So some tips for these patients. One, you have to document it, as I think Patipya sir was mentioning the importance of 10-2 program. 10-2 program or a macular program you should note this split fixation. Also, if it's rare complication, but still you should discuss with the patient. Sometimes maybe because of choroidal or maybe because of hyphema or unexplained inflammation, you have a decrease of vision. But at least the patient will tell you, okay, this particular thing was mentioned to me that the vision may go down after surgery. If you're comfortable with topical or subtenal anesthesia, that is a very good option. If you're giving a peribulbar or retrobulbar, stay away from optic nerve. Don't use lot of excessive amount of anesthesis. Avoid adrenaline. No compression, no balloon should be done because these are already compromised nerves. Post-operative IOP monitoring is very important on day 1, day 2. Sometimes when we have checked pressure, we get a pressure of 40, 30 on day 1. These 40, 30 pressure for 4-5 days is good enough to finish whatever little nerve is left in these patients. So in post-operative period or day 1, day 2, if you see high pressure, massaging can be a problem because that can start a leak. In these cases, a short course of oral Diamox or acetazolamide can be useful to prevent any harm to the optic nerve. Another problem in advanced glaucoma is a low threshold for complication. These are already compromised nerve. A little bit of choroidals, macular edema, hyphema, inflammation can lead to decrease in vision. But the problem is trabeculectomy is an unpredictable surgery, and even in the best of the best hand, you cannot totally avoid complication. So for this, again, it's very important you have to be really meticulous with your surgery. All the steps have to be very careful. Like cases like these where you see a lot of these patients with advanced glaucoma, patients are having drug allergy, ocular surface disease. These cases, you first treat the ocular surface disease, treat the drug allergy, remove the drug, give a course of oral Diamox. You can use mannitol to decrease the pressure. These things are important because that will enhance the overall success of your surgery. We routinely use low-dose fluorometholone for all our TRAP patients because most of the patients now are 3 on 4 medication and they do have conjunctival inflammation. If patients who are one-eyed, you can operate them early morning, remove the patch same day and see them in the evening. Then you can check the pressure also. Plus, it gives a psychological advantage to the patient because, one-eyed patient, when you patch them for 24 hours, it's very depressing and stressful for this patient. Also, a lot of time, patients are referred to you for surgery and there is a gross progression, before you jump for surgery, reevaluate the patient properly. Like this particular patient was planned for trabeculectomy because there was a gross progression in the period of just 4 to 5 months. But this was an unexplained progression. When we did a neuroimaging, we found patient actually had a sphenoidal carcinoma. So when you are having such unexplained progression, you are planning for surgery, have a proper evaluation of the patient, because once you have operated, somehow the onus of all the problem now comes on you. Intraoperatively, we use mitomycin routinely for all advanced glaucoma, for all glaucomas in fact, because again we need low target intraocular pressure. Pre-placed suture can be very important because it saves a lot of time in that crucial juncture. Use releasable sutures and go for slow decompression, especially in patients with high pressure. This is a patient whom you can see there is already a post-VR surgery done. We are doing a trap. Pre-op pressure was 40. We gave mannitol, pressure came down to 30. But once you open the eye, the pressure is 0. That time, it's the time when the blood vessels dilate, when you have this choroidal, suprachoroidal. If you have a pre-placed suture, it definitely saves a lot of time at that crucial juncture. In releasable suture, again, whenever you're giving releasable suture, you can have an option of going for a tight closure. So definitely you will have less chances of shallow chamber and post-operative hypotony. And later on, as per the need, after 3 days, 7 days, 2 weeks, you can always release the suture and increase the flow. Intraoperative atropine, a drop or a subconjunctival, can be very good in patients with shallow chambers and angle closure glaucoma to reduce your chances of malignant glaucoma. Postoperatively, again, have close follow-up, especially for advanced glaucoma. Try to see any unexplained high pressure and manage them. Whenever there is a complication, discuss with the patient. If you discuss the complication, it's much easier to manage, because if you're hiding, then you have to becomes more difficult to manage complication. In any patient with too much of bleb inflammation, you should use 5FU injection. This is a video of releasable suture. You can see the bleb is flat. It's been around 10 days after surgery. You can just pull the suture. Mostly after pulling the suture, you will see the bleb will start to form. And if it's not forming, a little bit of massage beyond the bleb is good enough to form the bleb. Yeah. Another issue we have seen with glaucoma patients is unrealistic expectation, especially patients who have been on treatment. Once they go for surgery, they feel probably the glaucoma will get cured, they will not have any progression. In advanced glaucoma, again, very important, you sit down with the patient, you discuss all the possible complications to avoid any unnecessary disappointment. I'll suggest you to please have a proper written consent in the language of the patient. Give it to the patient. Tell them, please read it, and you ask whatever question you want to ask. That extra 10-15 minutes of chair time will save a lot of time in post-operative period. Trabeculectomy is a very interesting surgery where the vision can go down but can never improve. So this extra time will definitely help you. What we always tell our patient is, yes, surgery has a risk of say 2 to 5% the vision may go down. But if you don't go for surgery, you can always be 100% sure that over a few years, definitely your vision is going to decrease. Also very important, don't try to become a Robin Hood. Don't try to take all the decisions on behalf of the patient. You discuss with the patient, tell them the options we have, but the final decision should always be patient's. Don't force the patient for surgery. If the patient is not convinced, don't force the patient for surgery. And the last point, I think, which Sumita Madam was also highlighting, poor compliance is very commonly seen in patients with advanced glaucoma. This is the reason why they are detected late. Sometimes they're not regular with their medication. They don't come for regular follow-up. But after surgery, also compliance is important. They have to come for regular IP checkup. They have to come for pressures. Just a surgery alone doesn't mean they don't need to be under follow-up. And that point also needs to be highlighted to these patients. To conclude, I say advanced glaucoma definitely has a high risk of blindness. Treatment is challenging, but don't delay the surgery for too long. Surgery is again the best option for patients where they are not controlled medically or with laser. And you have to have a team approach. It's a good idea if you have a corneal surgeon and a retinal surgeon with you, so that you can work as a team and give the best possible treatment for your patients. Thank you so much.
Thank you, Dr. Maneesh, for the excellent talk. And just again, 1-2 comments. In advanced glaucoma cases, you are planning for the surgery, see that there is no intraocular increase spike post-operative. One point very, very important. Even if it is temporary for 1-2 days, enough to knock off whatever little vision he has. So many people do the surgery in the morning, keep the patient in the hospital. After 2-3 hours, they check it whether the pressure is high, and once they're satisfied, they let the patient go home. More important than the high pressure is the low pressure. At any point of time during surgery, in immediate postoperative or late postoperative, intraocular pressure should not be low. I will tell you why this is necessary. Once the intraocular pressure is low to the extent of hypertony, not low means we need the intraocular pressure to be low in the range of 8, 9, 10, but it should never be less than 6, which we define as the hypertony. The reason being, once you achieve that pressure of the hypertony, there will be certain changes in the optic nerve head, which will worsen the visual prognosis for the patient. First thing happens is the lamina cribrosa, which is already thinned out and is already damaged, already flexible. Once the intraocular pressure is low, it squeezes the rest of the axons passing through the optic nerve head, it strangulates them at the optic nerve head, and the transaction between the optic nerve head from the retina to the brain is gone, the exoplasmic transport is blocked, and that will lead to, even if it is temporary for few hours, enough to knock out the vision. The second possible mechanism, that may be microaneurysms or micro or say blocks or for coagulations in the optic nerve head once the intraocular pressure is very low. And because the multiple clots in the optic nerve head, the vision goes. Third possibility is that is difference between the cerebrospinal fluid and intraocular fluid, intraocular pressure. So that difference will reverse the flow and will again affect the vision. So there are three possible very important reasons should be kept in mind to see that there is no hypotony even during the time during the surgery, because even the few seconds of flat antechamber and the atmospheric pressure and intraocular pressure is 0, the choroid expands immediately, instantaneous. And the choroidal volume is 480 microliters, antechamber is 150 microliters. So once it is collapsed, even the 20% of expansion which occurs instantaneously in the choroid is enough to cause a very shallow or the flat antechamber, enough to cascade the formation of the choroidal effusion or even choroidal hemorrhage, leading to still further lowering or high pressure. So important thing is keep in mind that hypotony should not occur in any point of time during surgery. Thank you, Dr. Maneesh, for the excellent